Welcome to the deep dive. Today, we're really getting into something fundamental for medical practice, burns.
Absolutely essential topic.
We're using a set of listener-provided revision notes. That's you listening to, well, pull out the absolute must-knows.
Yep, the high-yield stuff.
Our goal here is to make this dense information clear, memorable, basically get you up to speed quickly for revision.
And it's so important because burns are common, but they vary so much in severity. Having that core knowledge is just vital for knowing how to react.
Exactly. So we'll work through these notes, starting with, what a burn actually is, what causes them.
And who's most at risk, what's happening physiologically.
Yeah, and then the big one, what they look like, how we classify them by depth. That's crucial, isn't it?
Definitely. We'll also touch on how common they are, things they might get confused with.
Right, differentials. And then assessment, the immediate first aid, super important ongoing care, prognosis, and potential complications.
Sounds like a plan.
Okay, let's dive in. Based on these notes, when we say burns, what are we actually defining?
Well, fundamentally, it's an injury. Damage to the skin, sometimes deeper tissues, too.
Right.
And it's caused by exposure to something external, usually heat. But the notes are clear. It could also be chemicals, electricity, radiation, even friction.
Ah, okay. So it's broader than just thinking about fire or flames.
Much broader. You've got scalds from hot liquids, touching hot objects, corrosive chemicals, electrical currents, radiation like sunburn, and friction burns too.
Got it. So a wide range of causes.
Exactly. And the notes stress that how well someone recovers really depends on getting that initial care right and fast. Simple ones might be straightforward.
But complex ones need specialist teams.
Precisely. Multidisciplinary care becomes essential.
Okay. Moving on then. Who are the people most likely to get burned? Are there particular groups highlighted in the notes?
Yes, definitely. Risk factors are quite varied. Obvious things like working near heat sources, but age is a huge factor. The notes pinpoint two key groups: young children, specifically under 5,
Okay.
and older adults, typically over 75.
Right, the extremes of age.
Right. Exactly. Also, people with mobility issues or cognitive impairments, and even things like living in crowded or, say, poorly maintained housing can increase risk.
And for the little ones, the under 5s, any specific types mentioned?
Yes, scalds are very common, and contact burns from things around the house, irons, hair straighteners, hot drinks. It's a key area for prevention messages.
Knowing who's vulnerable is definitely key for prevention. So physically, what's going on when the skin gets hit by one of these agents? What's the pathophysiology?
Okay, so the burn source damages the skin cells directly, but it also harms blood vessels, nerve endings. This triggers an immediate inflammatory response. You get swelling, redness, but the damage and inflammation can lead to tissue death, necrosis.
And that's not just local.
No, and that's the crucial bit for severe burns. The inflammatory mediators can leak into the circulation, causing systemic effects, affecting organs far from the burn site itself.
Right, so a big burn isn't just skin deep, it's a whole body problem.
That's exactly why they can be so serious. It's a major physiological insult.
Okay, so thinking about what you actually see, what are the clinical features?
Yeah.
And does how much it hurts tell you how bad it is?
The pain question. Okay, so presentation varies massively with depth. You might see redness, feel pain, notice swelling, blisters.
Or even charred skin in bad ones.
Yes, or charred skin. And if there's smoke involved, difficulty breathing is a huge red flag for inhalation injury. Symptoms the patient might report include like dryness, the pain itself, peeling skin later on, blisters obviously, even eye problems if chemicals splashed.
Right.
But, and this is probably one of the most important takeaways from the notes for revision, pain level does not reliably indicate the burn's depth or severity.
Really? That feels counterintuitive.
It does, but think about it. A very deep burn might destroy the nerve endings completely, so it could actually be less painful than a more superficial burn where the nerves are intact but really irritated.
Wow, okay. That's a critical point. So if pain isn't the main guide, how do you figure out the depth?
That's where the classification system is essential. The notes lay out 4 main types based on how deep the damage goes.
Okay, let's break that down.
Right. First up, superficial epidermal. This is just the very top layer, the epidermis, like a bad sunburn.
Red, painful.
Red, maybe a bit white, definitely painful. But the key thing, no blisters. Usually heals within a week, maybe some temporary color change.
Got it. Number 2.
Superficial dermal. This is a partial thickness burn, goes into the upper dermis, looks red or maybe pale pink. Crucially, it blanches, press it, and the color fades, then returns.
Okay.
These tend to be extremely painful, and they typically do have blisters.
Right, so blisters and blanching point towards this one. Next.
Deep dermal. Still partial thickness, but deeper into the dermis. Skin might look patchy, red, or pale, maybe more extensive blistering. Here, sensation is often reduced, and it blanches poorly, if at all. Still painful, but maybe less intensely than superficial dermal.
Okay, reduced sensation, poor blanching.
Yeah.
And the last one.
Full thickness. This goes through all skin layers, potentially down to fat, muscle, even bone. The appearance is very different. It might look dense, white, waxy, leathery, or properly charred black.
And the pain.
Typically painless, because, as we said, the nerve endings are destroyed. Also, NO blisters and NO blanching.
So painless, no blisters, no blanching equals full thickness.
Generally, yes. Understanding those differences, pain level, blisters, blanching sensation, is absolutely fundamental for diagnosing the depth and deciding on management.
That classification is so helpful, especially knowing pain isn't the whole story. Zooming out again, how big a problem are burns? What do the notes say about epidemiology in the UK?
Well, they confirm burns are common, especially in those high-risk groups, young kids, older adults. Often happens at home or work.
Right.
In terms of numbers, primary care might see around 250,000 burn presentations annually. Hospital admissions are lower, maybe 0.29 per 1,000 people, including smoke inhalation.
And most aren't severe.
Thankfully, no. The notes say about 90% seen in primary care are non-complex. But, tragically, there are still around 300 deaths from burns each year in the UK.
Okay. Given the varied appearance, could you mistake something else for a burn, or vice versa? Are there important differentials?
Yes, it's always worth having differentials in mind, especially if the story isn't typical for a burn. The notes list things like erythema multiforme, cellulitis.
Skin infection, right.
Yeah. And more severe blistering conditions like SJS or 10 Stevens-Johnson syndrome or toxic epidermal necrolysis. Also, bullous pemphigoid and sometimes severe contact dermatitis can look similar.
Oh, other things can cause blistering or redness.
Exactly. History is usually key, but you keep these in the back of your mind.
Right. So someone presents with a definite burn. How do you approach the assessment systematically? What tests might you need?
Assessment starts with the clinical picture history, what happened, examining the burn. For anything significant, you use a structured approach, like ATLS principles.
The ABCDEs.
Precisely. Airway first is there evidence of inhalation injury. Breathing rate, effort, oxygen sats, circulation heart rate, blood pressure, assessing for shock, checking peripheral pulses, especially if there are circumferential burns, disability, checking conscious level, GCS, exposure, getting a good look at all injuries, but crucially, preventing hypothermia. Cover them up once assessed.
And what specifically about the burn itself?
You need to estimate the size, the percentage of total body surface area, percent TBSA. The notes mention the rule of nines as a common tool for adults.
Ah, yes, the rule of nines.
And you need to assess the depth using that classification we just discussed. And really importantly, check for those circumferential burns on limbs or the torso swelling under a tight, inelastic burn Escher can cut off blood supply. You have to check distal pulses, cap refill, sensation.
And always thinking about the cause.
Absolutely. How did it happen? Was it accidental? Could it be non-accidental injury? Especially vital in children and vulnerable adults. Also, associated trauma, did they fall? Was there an explosion? Time of burn is important, and check their tetanus vaccination status.
Okay. And investigations, blood tests, imaging.
For minor superficial burns, often you don't need any tests. But for major burns, yes. Baseline bloods are key. Full blood count, urea, and electrolytes.
Standard stuff.
If you suspect associated injuries, like from a fall or blast, CT scans might be needed: head, spine, chest, abdomen. For the burn itself, more extensive bloods for major ones, definitely FBC, UNEs, but also group and cross-match.
In case of transfusion.
Yes. Carboxyhemoglobin if you suspect carbon monoxide from smoke inhalation. Glucose, other electrolytes, maybe a pregnancy test. Arterial blood gases are really important for oxygenation and acid-base status. Chest x-ray often needed.
Especially with inhalation concerns.
Exactly. Cardiac monitoring is vital for electrical burns as they can cause arrhythmias.
Yeah.
And meticulous monitoring of urine output is crucial to guide fluid resuscitation and check kidney function.
That's a thorough workup. Let's switch to management. What is the absolute first, most critical thing to do right at the scene or on arrival?
Stop the burning. Seems obvious, but it's paramount.
Yeah.
Get the person away from the source fire, hot liquid, chemical, electricity.
Right.
Then get the clothing off. But if clothing is synthetic and melted onto the skin, or it's something like tar, don't try and rip it off dry. Cool it with water first.
Good point. What about chemicals?
If it's a dry powder chemical, brush it off thoroughly before washing. Don't wash the powder deeper into the skin.
Okay, brush, then wash.
Then the really high-yield step. Cool the burn with running cool tap water. Not freezing cold or ice water, just cool tap water. And do it for at least 20 minutes.
20 minutes minimum. That's longer than many people think.
It really is, but it's evidence-based. Helps reduce depth and pain. While cooling or immediately after, get off any rings, watches, tight clothing before swelling starts.
Makes sense.
And finally, after cooling, cover the patient. But cover them with something warm and dry, clean linen, blanket, even cling film loosely for small burns initially. The aim is to prevent hypothermia. They can lose heat incredibly fast from a large burned surface, especially after prolonged cooling.
So, stop burning, 20 plus mins, cool water, remove constrictions, keep warm. Got it. After that initial phase, what's the ongoing management?
It follows logically. You've done first aid. Now it's about proper wound care, pain management, preventing infection, fluid resuscitation if needed, and starting to think about rehabilitation.
Let's break that down. Minor burns first.
Okay, for minor burns. Clean the wound gently, maybe just soap and water or a mild antiseptic. Small blisters, say less than a centimeter, are best left intact. They act as a natural dressing.
Okay.
Larger blisters might need aspiration carefully, using sterile technique, maybe leaving the blister roof as a dressing. Then apply a non-adhesive dressing, perhaps with some gauze. The notes mention biological dressings are sometimes preferred, especially for kids.
And follow up.
Definitely reassess. After about 48 hours, burns can sometimes declare themselves as deeper over time. Superficial partial thickness might need a dressing change every 3 to 5 days. Watch for infection signs, give good pain relief, and check that tetanus cover.
Pretty straightforward for minor ones.
Right.
What about major burns?
Much more involved. Firstly, deal with any associated injuries. We talked about trauma, and especially inhalation injury. Airway swelling can happen fast and is life-threatening.
So, early assessment and maybe intubation.
Absolutely. Secure the airway early if there's any doubt, especially before transfer to a specialist burns unit. Monitor oxygenation with ABGs, maybe give high-flow oxygen. Elevate the head and chest if possible. Treat carbon monoxide poisoning if present.
And fluids.
Critical. Get large-bore IV access straight away. For significant burns, you need aggressive fluid replacement based on calculations like the Parkland formula to prevent hypovolemic shock.
We mentioned that earlier.
Continue cooling or irrigating if needed, especially for chemical burns, which might need flushing for 30 minutes or even longer for alkali burns. Dress the burns for comfort and cleanliness, but avoid wrapping tightly around a limb.
Because of that constriction risk.
Exactly. And if a full-thickness circumferential burn is compromising circulation or breathing, if on the chest, an emergency procedure called an escharotomy might be needed. That's cutting through the tough, burned skin to relieve pressure. And all major burns need referral to a specialized burn center.
Right. Any other key interventions mentioned?
Oxygen, as we said. Aggressive nutritional support is vital because the metabolic rate shoots up massively. Surgical debridement, removing dead tissue, is often needed for deeper burns. And specific dressings, like those containing nanocrystalline silver, are often used for antimicrobial effect and healing.
The notes also seem to separate prescribing and non-prescribing interventions.
Yeah, it's a useful distinction for revision. Prescribing covers the fluids, using formulas like Parkland, strong analgesia, possibly topical antibiotics or silver creams, and tetanus toxoid. Non-prescribing includes the actual burn center care, oxygen therapy, nutrition support, surgical debridement, escharotomy, and those specialized dressings.
That's a really clear overview of management. Looking further ahead, what's the typical prognosis? What influences the outcome?
It really varies hugely. Depends on the burn size, 2 BSA, the depth, where it is on the body, and crucially, if there are associated injuries like inhalation injury.
Which you mentioned is a major risk factor for mortality.
Exactly. The notes highlight 3 big predictors of death. Age over 60, having more than 40% TBSA burn, and having an inhalation injury. Any one of those increases risk, having multiple significantly more so.
But minor burns heal well.
Yes, superficial burns usually heal within about 2 weeks, generally without needing surgery and often without significant scarring. But severe burns can lead to long-term problems, physical disability, significant scarring, psychological issues, chronic pain.
Then prevention strategies are mentioned too.
Briefly, yes. Things like workplace safety, having smoke alarms at home, child protection measures, support for elderly or isolated people, and sensible sun protection. Common sense things, but they make a difference.
Okay, finally, what are the potential complications we need to be aware of after a burn injury?
There's quite a list. Early on, respiratory distress is a major concern, from smoke inhalation or burns constricting the chest. Fluid loss leading to hypovolemia and shock is critical to manage.
Good infection.
Huge risk. Burns destroy the skin barrier. Sepsis is a major cause of death later on. The body's metabolic rate increases massively, causing weight loss if nutrition isn't managed. Blood can become thicker, increasing risk of clots, like DVT or PE.
What about those circumferential burns again?
They can cause vascular insufficiency, cutting off blood supply to a limb, leading to distal ischemia. Needs urgent attention, possibly escharotomy. Electrical burns have specific risks. Muscle damage releasing myoglobin rhabdomyolysis, which can cause acute kidney injury.
Anything else?
Inhalation of toxic gases can cause direct poisoning. Hemoglobinuria from red cell breakdown or rhabdo can also damage kidneys. Long-term scarring is almost inevitable with deeper burns, sometimes hypertrophic or keloid scars, which can limit function and affect appearance. And never underestimate the psychological impact. PTSD, depression, body image issues are common.
Wow, that really covers the spectrum. A very thorough deep dive, pulling out all those essential points from the revision notes. We've traced the journey from the moment of injury right through assessment, complex management, and potential long-term consequences.
Absolutely. I think the really high-yield points to hammer home are: understand that classification by depth and don't rely on pain alone. Nail the immediate first aid, especially that 20-minute cooling. Recognize the red flags, inhalation injury, circumferential burns, and know who's most at risk.
Great summary. So what does this all mean for you revising this? Maybe think about this. Given everything we've said about pain not correlating with depth and the clear signs for each classification level, how can you consciously use those objective signs, blanching, blistering appearance, sensation, to build your assessment, rather than being swayed primarily by how much the patient says it hurts? It really underscores the need for systematic, objective assessment. Thanks so much for joining us for this deep dive on burns. Hopefully that's given you a clear, memorable path through the key information. If you are revising for the MSRA, do check out pathomsra.com for comprehensive resources. And for fantastic free revision materials, head over to freemsra.com. We'll be back with another deep dive very soon.